I don't know how many people here know Dr. Kent Lloyd, but he's from a veterinarian from the Department of Veterinary Medicine. He's had a mouse biology lab where he creates a mouse to pretty much to order for just about any disease state. He can create all kinds of things for you. And he is one of the most renowned researchers here at UC Davis. So we're very lucky to have him within our Department of Surgery. And he's going to talk to us today about precision medicine and some very great ideas related to that.
Well, thanks very much, Tina. I appreciate that. And I don't know if I totally agree that I'm the most renowned researcher here, but I have to say I've only been in the department for a couple of years, and I really enjoy being here. It feels like home. I started in the Department of Surgery down at UCLA actually, and I came up to veterinary school and then moved over here. So it's really been a pleasure to be here. So I wanted to spend about a half an hour, 30 minutes, 35 minutes with you talking about, kind of giving you an update of where the nation is and even parts of the world are with regards to this precision medicine initiative. And then Dr. Fred Myers will be speaking after me to tell you what UC Davis has done. So it'll be a bit of a tag team approach here. So obviously I got to talk about disclosures, so no relevant or related financial relationships. I won't discuss any off-label use of medications. All my materials are available for review, but I do have one thing to disclose, because I did bring a friend with me today to influence your thinking.
21st century businesses will rely on American science and technology, research and development. I want the country that eliminated polio and mapped the human genome to lead a new era of medicine, one that delivers the right treatment at the right time. In some patients with cystic fibrosis, this approach has reversed a disease once thought unstoppable. So tonight I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give all of us access to the personalized information we need to keep ourselves and our families healthier. We can do this.
Kind of looks like a Department of Surgery retreat, doesn't it? Well, anyway, so obviously there was a lot of buzz back there when President Obama talked about and introduced the Precision Medicine Initiative back at the 2015 State of the Union address. But was it more marketing than science? And then also, was there more hype than hope? And that's really kind of what I want to talk about today, to give you a very balanced, hopefully a balanced perspective of where I think things are going. Let's first look at what he was referring to when he was talking about precision medicine. So the instant messaging message is defined here. It's the right therapy in the right amount to the right patient at the right time, and that really does sound good. And the idea was to get Congress and ultimately the general public engaged in a bold and exciting new idea. But really what it reflects is that there's a dramatic rise in the ability to obtain very, very large data sets that what the hope was that could be provide more relevant details in order to drive medicine. So perhaps another way to put it, maybe less glib than the instant messaging approach, is that matching therapy to a specific diagnosis based on an individual's molecular characteristics, environmental exposures, and lifestyles, behaviors, and actions. And it's also been referred to as, but different from, personalized medicine, individualized medicine, even P4 medicine, P4 referring to predictive, preventive, personalized, and participatory. And in 6 months, there'll probably be a new moniker for it. But really, medicine has always been personalized, hasn't, and certainly surgery has always been quite precise. So I think the distinction that he was trying to make, that is in the past, the only tools that we had to personalize care weren't as precise as they could be. Things like family history, comorbid conditions, patient preferences, and aspects of history, patient history that might impact which treatment would be most appropriate, such as genomics and other omics technologies. And those can be used then to offer really significant change to the way medical care is delivered. But it needs to be balanced with too much information so that it doesn't paralyze decision making. So it's obviously not a new concept, probably because the inability to determine mechanisms of disease pathogenesis. Hippocrates understood the focus needs to be on the patient and not the disease. And here is quote, "It's far more important to know what person the disease has than what disease the person has. We've all heard of things like the person is possessed by the devil, so this is the same type of concept. Now, it can be argued at a superficial level that we've been applying precision to medicine, and even in my case, veterinary medicine, for years, at least when it comes to treatment directed at individual characteristics or pathologies. And the whole idea has had more than 2,000 years to evolve, but today's idea of precision medicine is different, and it was encapsulated in this NRC report published in 2011, which really then changed the idea of what precision medicine is. So very specifically, the report envisioned a comprehensive disease classification, so a new taxonomy that combines information from biomedical research, public health, and healthcare delivery communities towards advancing knowledge of disease pathogenesis and improving health. And the report expressed concern that the use of the term personalized can imply that treatments and preventions are being developed uniquely for each individual, which was not its intent. So initially, the focus of precision medicine is to explore how treatment or prevention approaches can be developed based on a combination of genetic, environmental, social factors, which could target persons or populations. And in fact, these type of approaches actually may lead to non-personalized interventions that could be applied population-wide. And the concept has had time to catch on. So as you see here in the left panel, this is just a diagram of the Google access or Google search results for personalized medicine, shown in red, and in blue, the relative interest in precision medicine. And you can see here at the time of Mr. Obama's speech, 2015, the search for precision medicine spiked. And over on the right, just look at the publications 2005. This is a combination of personalized and precision medicine publications in the title or abstract, and how it shot up quite dramatically in 2015. So with all this rational exuberance, there were some rational concerns that served to balance the hype. And there were those who immediately recognized the challenges, hurdles, and even deflection from real needs that could hamper medical progress for all. Things like this moonshot medicine. This is by Michael Joyner, who's an anesthesiologist at Mayo Clinic, talking about the amount of data was just going to be too much to handle, the specificity of the data from this New Yorker article, and then the idea is really, was it more marketing and politics than the reality? And then a very cogent article here in New England Journal of Medicine just last year regarding how maybe the whole idea of precision medicine was getting us off the rails in terms of real needs, in terms of health disparities and health equities. And then I'm trying to get the message out that we need to go beyond just using statistics and data and actually testing and validating what we think are actual causal mutations or other associations with disease. So despite the disagreement or people on both sides of the issue, I think we can all agree on there's challenges that are due interventions, and I list them here. First, that many diseases lack effective preventive strategies, diagnostics, or treatments, and the options that currently have often fail to consider key differences among individuals, their genes, their lifestyles, their environment. The participants in biomedical research, as we know, they're often treated as subjects and not partners. And again, to keep with the P theme, as we move towards precision medicine, it's important that we also don't consider them merely data points, but they're really partners. The research findings, I think we all agree, take too long to be implemented into clinical practice. And importantly, we need to look beyond the genome. So this was an article by Sam Hogwood from UCSF last year in Science Translational Medicine, in which he was trying to define where we're at currently. And he defined this as an inflection point here, where he's talking about our ability to gather data. In fact, immense amounts of data now are maxing out. And we're now at this inflection point where it's important, in order to move forward, that we can now use data information services to integrate, interpret, and apply this data to medical practice. So in this context, this precision medicine is really a knowledge network, as he defined here, maps very similarly to how the Google Maps approach. And it's made up of two principles: the integration of data from numerous sources, as seen on the left, and then the output from that data to group populations of individuals, shown on the right. And the vision then for precision medicine is in this clinical ecosystem, in which it's long-term, it's collaborative, and it's personal. So on the bottom here, we see an health event timeline for an individual, and let's say this is a very engaged patient, also known e-patient or an internet patient, sometimes they're called, where all their data, not just their history, the examination data, but genomics, omics data are all fed into this knowledge network. And this knowledge network then is able to inform research, and there's a back and forth to increase the research activity that then feeds into building this knowledge network, which then can inform clinical interventions and treatment, and hopefully treatment that's effective and therefore predictive. Well, why did the president think now was the time to do it? And there were really 5 tipping points in medicine, science, and engineering that he felt was the time to go forward. So I tried to, you don't have to read all this, but I tried to highlight these in red because they focus on the ability, the low-hanging fruit, the ability to actually sequence the genome faster and better than ever had been done before. The advent of electronic health records were now being adopted across the country. The availability of devices in engineering to monitor a person's health, just like you can't see it, but the Fitbit that I'm wearing and that most of you probably wear. The increasing sophistication of bioinformatics tools, which would be essential to be able to interpret and make sense of the data. And finally, the idea that people wanted to be participants and not just patients in their health care. Now, you might not know, but this whole idea was proposed twice before. In 2004, this is a paper by no less than Francis Collins, who at the time was the director of the National Human Genome Research Institute before he became director of NIH. And he proposed at that time that we should have a 500,000, not a 1 million, but a 500,000 patient cohort in which we studied quote-unquote personalized medicine and looked at the interaction with genes and the environment. And then in 2006, this very unknown person at the time, Senator Obama from Illinois, actually introduced Senate Bill 3822, which actually proposed an initiative in personalized medicine. And of course, it was the combination of these 2 guys later on that actually pushed this forward. So if we look at how the landscape has aligned for testing today, I think this table really shows it quite starkly. You can look 10 years ago versus today in terms of the cost of sequencing the human genome, $22 million 10 years ago to about $1,000 today. The amount of time that's needed to sequence a genome from 2 years to only a few hours today. The number of smartphones in the U.S., less than 2% 10 years ago to more than 72% of the population with smartphones that actually then can be used for engaging this mobile health technologies field. The adoption of electronic health records, computing power that's increased a quadrillion-fold over 10 years, the cost of data storage, and then the increase in interest in participatory medicine by patients. Well, it's all about money, right? So in terms of authorizations and appropriations, the president then, after making that announcement, then went to Congress and said, look, I need $215 million, and I want to distribute it this way. $200 million going to the NIH, split between the Cancer Center and the National Cancer Institute and this patient cohort I'll talk to you about in a moment. Some of it went to the FDA, and also some of it went to the Office of the National Coordinator for Health Information Technology, which is also part of DHHS. So now, being a 2016 budget, this should have been approved quite a long time ago, but it was really only approved in a budget agreement in October of last year after this 2016 had started. Now, the 2017 president's request is $300 million just for this part of it. I wasn't able to find figures for FDA or the ONC, so it's at least $300 million. That was presented to Congress, and of course, on Monday when the president always introduces his budget to Congress, and it was DOA, and negotiations are underway. And part of the reason why it was DOA is because there was this battle between the president and Congress regarding funding for the NIH, making some of it mandatory versus discretionary. NIH's budget, just like all our R&D, even military, is discretionary. So the New England Journal of Medicine published this article here on the left. Again, Francis Collins, it was just last year, in which he outlined the details of what the president's initiative was. And then finally, after numerous workshops, most of last year, the advisory committee to the director of the NIH published a plan, more than 150 pages, in order to roll out the Precision Medicine Initiative. So we know it today as the Precision Medicine Initiative, and there's 2 components. There's one component that's targeted, as I mentioned already, to the NCI, and essentially the idea is to target cancer therapies such as and investing in innovative clinical trials such as NCI Match, use of combination therapies, and understanding drug resistance. And then the other part is this 1 million person cohort program, or the CP, and the idea is to look at a whole host of things that might be able to help in terms of improving healthcare for individuals, collecting data, collecting blood samples, looking at lifestyle information, and so on. So I don't want to diminish the importance of the cancer part, but I do want to focus the rest of my talk just on the cohort program. So what are the core values of the cohort program? Well, first, it's open to interested individuals, and it's important. It's not just the sick, it's also the well. The idea is to represent the rich diversity of America. The participants are encouraged to be partners, which is an interesting term. On the superficially, it certainly sounds good, but thinking about it, it's more than just a kumbaya. It really needs to be a true two-way partnership. The participants also will have access to study information. The data, though, at the same time can be accessed broadly for research purposes, and of course, therefore, that requires a strict adherence to PMI privacy principles that were outlined by the White House a few months ago. And then also the Precision Medicine Initiative should be a catalyst for progressive research programs. Well, does the public support this? Well, the NIH Foundation did an opinion survey, and maybe because of those they surveyed, they found that there was dramatic support for this. Almost 80% agree that probably definitely should be done. More than a half of the people thought that would probably definitely participate in the cohort. And what motivates their participation, large numbers felt that they were interested in receiving the results of their own study and wish to advance health research. And most of the participants in the survey felt that the patients should be partners with the researchers. So what are the scientific opportunities in the PMI? Well, there's numerous ones, and probably the key one is the ability to develop quantitative real-time estimates of risk for a range of diseases. Again, just beyond cancer, but a whole host of diseases, by integrating these different data sources. Identifying the cause of individual variation in response to therapeutics, so pharmacogenomics, discovering biomarkers of disease, using mobile health technologies, developing this new taxonomy of disease classification and relationships, empowering study participants, and then creating a platform to enable trials of targeted therapies. So assembling this cohort is going to be a big deal. There's 1 million or more U.S. volunteers, again, reflecting the broad diversity of the United States, with a strong desire to focus on underrepresented and underserved groups. It's a longitudinal cohort, so bringing them in, you want to keep them because you want to sustain the studies over time, and also be able to provide not only EHR data, but biospecimens, surveys, and starting with a baseline exam. There'd be two methods for enrollment. One would be direct volunteers, and second would be through healthcare provider organizations. And obviously substantial patient engagement and development, implementation, and certainly governance. And they've proven that's the case, and I'll show you in just a few moments. Okay. So what's the benefits, though, of this approach to the CP? And the fact that it's going to be large and diverse. By doing so, and actually in long term, it'll be less costly and less difficult than representative sample, which is, as those who do clinical trials know, that it's oftentimes very difficult to achieve. You're able to generate estimates of effect and association, but this is the hope. And this is where I feel that using statistics only to generate estimates won't be enough, but you do need model systems in order to test and then validate those associations. And then it also permits well-powered samples to an extent. We'll have to see how many people and what diversity of symptoms and diseases that they have. Again, the support is focused on underserved and underrepresented populations. There's an opportunity for seeing prospectively understand resistance and development of disease, and then the idea is to complement and not duplicate existing disease-specific cohorts. So the core data set will be stored in a coordinating center. They'll be aligned with other data sets when possible, and then leverage existing data standards and common data models. And there'll be a whole host of data measurements, from self-reporting measures, baseline exam, the AHR biospecimens, and also the data contained in mobile health. So the information flow in begins with two patient populations, or a person population, let's say the direct volunteers can actually contribute their data directly, as well as the volunteers from the HPO organizations. They will also then see their providers, who then provide the baseline exam of biospecimens, so that goes into the biorepository, and then all the data then goes into the cloud. So that's the data flow in. terms of the data flow out for use for research, the data flow out then can go into the research laboratory with data. I'll do it over here. The data here with the specimens, so integration of this data and feeding back to increase the knowledge network. The data can then flow back to the person, volunteers, and the patients, and then out to the public for general use. Obviously, there's policies that are needed for the PMI cohort program. There's a desire to have a single institutional review board, a single common IRB to facilitate entry into the program. There's obviously the needs to look at privacy and security, and looking to clarify CLIA and HIPAA, and also there needs to be special policy considerations about enrollment and retention of children, the decisionally impaired, and those who become incarcerated. Now, the governance structure, I think, is very interesting. They just recently named the PMI cohort program director, and this was just April of this year, and Eric Dishman was named the director. He's a former fellow and general manager of Intel's Health Strategy and Solutions Group. Now, what's interesting about him, he's not an MD, he's not a Ph.D. scientist, he's just a person, but he's actually, he's just a person, nice guy. But the key things about what I think they're sending a message with this is that he's actually taken advantage. He's been a patient in terms who's suffered from renal cancer, a very difficult one over many years of his life, beginning when he was in college. He then took advantage of a genomics approach to actually find targeted therapies for his cancer. And on top of that, again, as I said, he was a member of Intel's Research Strategy and Solutions Group, so he's really a data diva. So I think this combination of characteristics of an individual to lead this really sends the message of how they want PMI to roll out for the public. There's an advisory panel that he leads, an executive committee, numerous steering committees, and obviously a need to maintain interagency coordination. So the overall structure of the PMI looks like this. There's a coordinating center. In blue, you see those things that are already out in terms of mechanisms for funding. The healthcare providers and the direct volunteers program over there on the left, and then on the right, the Participant Technology Center, the Biobank, and under development for research funding are the exams and specimens component, the laboratory analysis, and the how to enroll the federally qualified health centers into this process as well. So here are the funding opportunities in the PMI. These have already been released, so there's a number of them, and the amount of money you can see here. A number of awards have indicated here what their project periods are. The application due dates are already passed, and several of them we're waiting still to hear about awards, and Dr. Miles talked about the ones that UC Davis is involved in. And the hope is that by the end of this year, remember this was the president's initiative, he wanted to go out, and of course he'll be looking for a job after December, so he wants something to come out of this by the end of this year. So the idea is that by the end of 2016, there'll be direct volunteer recruitment and engagement strategies that have been a pilot that have been completed. There will be pilot results used to design and launch the scale-up of the direct volunteer program. You can't volunteer yet, but that should start to happen in July. There'll be strong partnerships with 5 to 7 healthcare provider organizations. Hopefully we'll be part of that. And if successful implementation of test recruitment sites at the FKHCs. This is an interesting number, 79,000 engaged participants fully consented and enrolled in the cohort. How they came up with that 79,000, I still don't know, and I don't know if anybody knows, but they feel that if they get to 79,000, that there will be a success for this year. Collection of biospecimens from at least 25,000 of those enrollees. The Sync for Science FIRE method, which is really an internet method for allowing volunteers to push their data to a central coordinating data collection site, and then a functional data platform to allow collection of different types of data, and then a couple of research studies using the cohort data underway. So what's under development? The common IRB is under development, the Sync for Science pilots, converting the FQHC pilots into full implementation, under development of what the health exam, the initial baseline health exam will look like, how the biospecimens and what biospecimens will be collected, and how to do it from volunteers, how to engage practitioners, nurses, community providers, and other allied professions, how we use the research data, and then obviously regulatory and reimbursement policies. Now, there was a White House summit in February of this year. It follows the second mention. Again, I'm not going to play it for you, but The president did mention precision medicine again at his State of the Union speech in January this year. And of course, it also followed it was a one-year anniversary of the launch of PMI. And at this time, it emphasized sharing data with consumers, and most importantly, it announced the first funding in the entire PMI program, and that was for the Direct Volunteers pilot study, and that was awarded to a consortium of Vanderbilt University Medical Center and Verily, which is previously known as Google Life Sciences. So they actually got the first award in this, and so they're working now on setting up the overall structure as well as the internet site where you can go on and log in and join the program. There are also obviously related programs underway. We have our own program here in California, the California Initiative to Advance Precision Medicine. The 2 awards were already announced, and UC Davis participants in that. And again, Dr. Miles will probably mention that. Genomics England have been going now for a couple of years, and even China recently announced their actually interesting, very cautious, and I think very thoughtful approach to moving forward. They're not talking about 1 million persons, they're talking only about a few tens of thousands of persons to begin with, but obviously with the idea is they want to get this bigger and bigger. And there's a whole host of smaller programs around the world, Iceland, Bulgaria, a number of places. Now, there are a number of challenges that remain. There's a limited number of pathways that are identified, limited number of genes that are annotated, and limited number of actionable alleles today. And these mean today, without more data, how many targets can be actionable? Can targets be actionable? How many targets do you need to hit? Will the targeted therapy kill only the susceptible or have an effect only on the susceptible alleles? How do you prioritize targets and drugs? And what about the availability of clinical trials? So numerous questions still remain moving forward. Obviously, the challenges regarding analysis of data across multiple platforms, the focus on the genome, as is currently the case, is likely to be oversimplistic. There's a profound number of potential targets, and obviously single agent cures are not likely in the short term. So this is, for me personally, why I'm advocating for a dual approach to data analysis that includes testing and validation. It's something that we're trying to do, as Tina mentioned, in our mouse program with our International Mouse Phenotyping Consortium, our Knockout Mouse project, where before you're able to identify which genes or alleles actually could be pathologic, you need to do what the normal gene does. And greater than 50% of the genome, we don't know what its functional role is, and that's what we're trying to do in simple mouse models. So it's a work in progress. Precision, and so just a few ideas about, before I finish, just a few ideas of where I think we need to continue some thoughtful input into, and that is really, precision is not enough if it's going to have an effect. The precision, and if it's going to have an effect, then it will be predictive. So precision is only predictive when it is actually effective and it actually changes the course of a patient's outcome. A patient engagement versus patient autonomy. The idea that patients being partners is a good, superficially it seems like a good concept, but really the patient partnership and engagement is a lot more than just having the patients say they're going to give you all their data, but there really has to be a back and forth. I'll say it again, I think in vivo modeling will be essential in order to accelerate advances in this case, in order to determine causation from association. There still needs to be a focus on overcoming health disparities and focus on health equity. Obviously, there needs to be an impact on healthcare expenditures and how to ensure that the expenditures that will be great in the beginning of this we can actually help to reduce those expenditures over time as the therapies are now targeted to patients in a more targeted way. How to engage all the other omics, metabolomics, proteomics, transcriptomics, as well as genomics, and integrate with that with environmental data. How to engage education and training, not only in medicine, but in the allied fields, and even in veterinary medicine. How to go about pushing this forward to precision public health away from not just individual health, and ultimately how do we engage in building a learning healthcare system. So I'll finish up with this, that I look at precision medicine and precision health as a pyramid that aspires to be a tower, and it's based on the advances of data science, increased computing power, reduced sequencing costs, and functional electronic health records. And obviously building on that, then precise diagnostics, targeted, more effective therapies, reduced morbidities, longer, healthier lives, ultimately some cures, but then focusing on prevention strategies and hopefully building on that to improve health equity across the spectrum. So in closing, I hope I've made my case for rational exuberance being behind the excitement intensity of precision medicine, but I think we need to remain focused on the science and not be beguiled by the hype. And I think this was best said by David Gorski in a blog post last year, in which he said, medicine that works is just medicine. So, thank you.
Well, you're just about at your attention span, so I appreciate that. And I'm just trying to make a few comments to augment what Ken has talked about. I'm here really to tell you that the Department of Surgery is really engaged in precision medicine already. And it's been great for me to be able to work with you, my friends and colleagues, to talk about some of these things that you've heard about, that it's real already in the department. So these are the four areas that Kent kind of talked about, that precision medicine involves these four domains of person characteristics, markers, whether it's omics or imaging, the environment that people come from, and then behavioral and social aspects of medicine. It's really bringing these all together in that knowledge network that we hope will inform us in how to treat individual patients better and how to understand population health more accurately. And most importantly, it's that interplay between individuals and populations that really forms the basis for precision medicine. Now, I know a lot of you are interested in global health. That's become a real marker of this Department of Surgery. And so if you look at this, you could say, well, those are all the aspects of global health, of international health. How does that differ from precision medicine? And I think I would say that it really doesn't. There's a lot of overlap. It just happens to be where you're looking at that. If you look at some of the international aspects of surgery, if you look at international aspects of young children growing up, all of those domains are exactly the same as it is with One Health and a learning healthcare system. So this is not an effort to set up a whole new career for me. Well, okay, maybe it is. Or a whole new effort. This is, in fact, a way to make much more cogent a lot of the efforts that you are involved both globally as well as locally. So what we're talking about is making more precise future probabilities. And in these three categories, we talk about it's a risk to your wellness, it's a risk to recurrence or prognosis, and it's a prediction of response or resistance to therapy. Those are the three areas, the practical things that you're already involved in and that we think precision medicine can take us down this pathway. So Kent's already talked about the risk to wellness in terms of the National Precision Medicine Initiative, which really has great roots in this country, for example, in the Framingham study. But here's a surgical example. You know, Dr. Palmieri has talked to me about her interest in risk to wellness to prevent trauma. And if you think about those four domains of person characteristics, the environment they come from, and behavioral elements, that's a precision medicine initiative. So risks to wellness in terms of trauma prevention, and you know, you've done a fantastic job as a department, and under many of your leadership, we see less trauma, better outcomes, burn prevention, etc. So you think about risk to wellness, it can be this large national cohort, but it can be local cohorts too in terms of risk to wellness. How about risk to recurrence or prognosis? And Kent emphasized cancer recurrence. When I see a woman with breast cancer in the cancer center, oftentimes we'll say you have a 70 to 80% chance of cure, and her response is, am I in the 70% or the 30%? That's not very precise enough, and we do more and more to be precise in that situation. It's a little bit like buying, someone said, mutual funds, right? You can buy a mutual fund and you've got overall good good outcomes sometimes, but you really want to know picking the winners and the losers out of all those stocks in order to be more precise. I've been really having fun with Joe Galante and Dr. Jerkovich and many other people thinking about a similar situation in trauma. So I'm one of your best students. I'm trying to understand, you're trying to understand, using these domains of person characteristics, omics, markers, metabolomics, the environment they come from, poverty, microbiome, nutritional status, and behavioral and personal characteristics. Who are the 70 to 80% of people who are going to have a good outcome in trauma? And who are the 20% who are likely to have an adverse outcome in trauma? And how do we do something different for that group versus the group that's doing well? So that's a prognostic abnormality. And you're very, very involved in that, and I'm learning a lot from you. And then finally, there's the prediction of response to therapy. Can genomics help us to understand who is more or less likely to respond, and can we select therapies specific for, in this case, cancer? And Bob Cantor and Dr. Murphy are really leading the area, both in terms of comparative immunotherapy using both human and animal models, but helping us to understand much more accurately who is more or less likely to respond to immunotherapy and how we can augment the responses we already see, or who shouldn't get therapy, or who's, because those cancers, for example, and it's going to extend infectious disease also, are less likely to respond to therapy. So you're involved in all three of these domains of precision medicine: risk to wellness, prognosis, and prediction of response or resistance to therapy. And it's really the element of bringing these four areas together in a much more sophisticated way, building large databases. Well, wait a minute, databases, you have databases. You have TQIP, you have NISQIP, you have your transplant database. You've already developed databases within surgery that are the elements of the type of large data that Dr. Lloyd was talking about. And now we need to understand both retrospectively and prospectively these other elements so we get a feeling for population health and then how we relate it to individuals. That could be true in vascular surgery. That could be true in a number of other areas. But you are already doing precision medicine in a much more sophisticated way than many, many other people are doing. And I've learned a huge amount just by talking to you. It really also then is this population health, understanding, for example, the Central Valley we work in, kind of an element of global health, if you will, and relating it back and forth to individuals. Our goal is to improve population health, but it also is by understanding the heterogeneity of groups within these populations, how we then can begin to understand individual patients. And we do that already. I see a person in the cancer center with breast cancer. I don't say, well, in my experience, this. No. Say, I understand the literature in breast cancer. There's heterogeneity within breast cancer. And now using phenotype and genotype and background, I can better provide this woman an assessment, a prognosis, and prediction of response to chemotherapy or hormonal therapy. The same is going to be true in trauma, where we look at this heterogeneity of populations that we call trauma patients or transplant patients, and then are better able to relate that to individuals. We already do that. You already do that. You do it either explicitly or intuitively. What precision medicine allows you to do is to develop new teams of individuals who can take advantage of new data sets and new tools, informatics, and new partners, including patients who want to participate in these types of studies, to better understand the heterogeneity and therefore tailor prognosis and therapy for our patients who come to us who are ill. That's in essence the excitement that Kent and I feel for precision medicine. It's new teams, people working together, using these remarkable new tools of data sciences, and prediction of response to therapy to do something that we always have done more precisely. And I think you're able to do that. And we're going to pull that together at UC Davis. We're pulling together both the health system and the Davis campus. Which campus in the University of California, for example, has the strongest reputation in environmental sciences? Well, it's Davis. And people are very excited about what we can do, whether it's microbiome, poverty, nutrition, all of the things that make up the environment, air and water pollution. Davis brings a very, very strong background to that, and we can take advantage of our strengths to contribute something very unique to this emerging area of precision medicine. I'm not going to go through how we're organizing ourselves, but we do have 4 working groups. We have some cutting-edge ideas that I think can be very, very helpful. We'll be engaging many of the people within the Department of Surgery as well as across the schools of medicine and nursing to really be fully participating and helping us set a vision for where we want to go in precision medicine at UC Davis. We're doing stuff. We're trying to be out there. We have, as Kent said, we're part of the National Precision Medicine Initiative. We put in for one of the hiring incentive programs on the Davis campus. Our big idea for fundraising has been accepted as one of the best across the campus, and we see this big idea in precision medicine as an umbrella to bring everybody in. It's not my big idea. I haven't had a big idea in about 25 years, so I'm really hoping that all of you will help me with this. It's really a big idea that all of you can participate. Okay, it's been 15 years. Come on now. This is going to be very, very exciting for us to work together to get out into the community and do some real fundraising to let people know that we've got something very unique at UC Davis to contribute to the national effort in precision medicine. We've put in a training grant. We have a strong collaboration with UCSF. We hope to have some pilot grants this coming year, as well as a target approach to campus-wide engagement. We'll have a town hall in the fall of 2016. And the California Initiative to Advance Precision Medicine, CIAPM, we have a strong partnership with them, both in the governor's office as well as their central office at UCSF. So there's really room for all of you in this initiative. Some of you are interested in precision medicine. This is from an article in JAMA just last week. Some of you are interested in the research aspects of precision medicine, which is good. Join us. But some of you are interested in how we take that knowledge and implement that within a learning healthcare system. How do we go back and forth from research to clinical excellence? And then some of you are interested in this emerging area called implementation science. How do we take the knowledge generated by clinicians and researchers and make it sustainable? How do we have sustainable improvements in both population health and clinical care? Oftentimes in academics, we get right up to the precipice of our research, and then we never implement this within our health system or in our communities to improve the overall health care and population health. So there's room for all of you within this initiative, both within the Department of Surgery and across the health system. And I'm really excited about the efforts you're already making in this area. I've learned a lot from you, and I expect to see a lot more in the next few years. So thank you very much. Appreciate it.
We've got a few minutes for questions. Gentlemen, thank you very much for a wonderful summary of where precision medicine is, and Dr. Lloyd, how it came to be and where the initiative is coming from. It really puts it in a great perspective for how it's going to affect our campus and all of our research efforts. Questions, please.
For either you, Fred, or Kent, one of the great challenges associated with maintaining a longitudinal database has to do with dropout, loss to follow-up, et cetera, particularly after patients have had an interesting outcome, the first major stroke, whatever. Suddenly the familiar mechanisms of follow-up are disrupted. And frankly, one of the great barriers to database maintenance has been the rules which forbid linkage to other national databases. And it sounds like folks in the PMI initiative have thought about this, and how has that problem been?
If you sign up to be
solved?
one of the million
You
people in the
volunteer to-
PMI initiative, you sign consent that all of your electronic health record data will be uploaded quarterly, so that will be automatic follow-up. But I agree with you that long-term dropout is always a concern with these, and so there's going to have to be interoperability. But the people at PMI Central are going to have to think about this. I think this is a big issue.
Yeah, that's a very good point, and it is an issue, and that's where the Sync for Science pilots are coming in, because it is giving the control of some of that to actually the participant. If they are excited and enthusiastic to participate, the thought is that they'll be willing to then work at it in order to make sure the whole program works. So the Sync for Science is an idea to actually get them control of their medical record and information and be able to push that forward into the national database. So it's one part of being able to link databases. There's other efforts afoot in order to align existing databases like the Million Veterans Project and other projects in order to align that all so that there will be the ability to read this data across platforms.
Other questions? Opportunities for involvement.
Call me, call any of us. I think opportunities for involvement are really robust, and I think we have some very unique things. I doubt anyone else within UC is doing the kind of things that we're doing in trauma, burns, et cetera. And there will be a call for grants from the California Initiative to Advance Precision Medicine. Within the next couple of months, the governor has $10 million rather than $2 million in the 16-17 budget, and we expect, and we all expect to see proposals from across UC. It'll be opened up to all the other universities within California also, but they'll be looking for precision medicine initiatives, probably that involve more than one university. So we should be anticipating that and trying to pull that together now rather than waiting until the call coming out.
Before we conclude, it's certainly staggering to see what a single decade has done for information management in this country, from whether it's cell phones or being able to do the human genome. Just what's happened in one decade is staggering. Just think about another decade from now where we'll be. It's really
It
an
is
exciting
staggering.
part
The
of it.
ability to upload Dr. Lloyd's Fitbit to his iPhone and from the iPhone to our electronic health record alone, which is what we've done at Davis now, is just a remarkable step in all of the other technologies. So there's a lot of gaps still, but people understand what the gaps are. And although I agree with Dr. Lloyd, there's a balanced discussion here about hype and over-promising. It's an exciting possibility.
Well, thank you for joining
Thank
us
you.
this morning.